Hi everyone, in this video I want to talk about the different types of periodontal flap surgery. First, I'm going to talk about the indications of periodontal flap surgery. We're going to discuss the different techniques that can be used, and in the end we're going to talk about how to choose which flap to use in our patient. The references for my slides are from these two books, Neumann and Carranza's last edition and Linda's Clinical Periodontology and Implant Dentistry. Also, I've added some additional material from different articles. Indications for periodontal surgery after phase 1 therapy include the following. The first one is when the area has irregular bony contour, deep craters, or other bony defects that need to be accessed by flap surgery. The second one is when we have deep remaining pockets after phase 1 therapy that are not clinically accessible, neither for the patient nor for us. The third one is when we have a furcation involvement, which is grade 2 or 3. The other indication is when we have intrabony pockets that exist distal to the last molar. And in the end, when we have persistent inflammation after phase 1 procedures, it indicates that in there exists a moderate or deep pocket and subgingival deposits that need to be accessed by periodontal surgery. First, I'm going to talk about the original Widman flap. In 1918, Dr. Leonard Vidman published one of the first detailed descriptions of the use of a flap procedure for pocket elimination. In his article, The Operative Treatment of Puria alveolaris, Dr. Vidman described a mucoperiosteal flap design that aimed to remove the pocket epithelium and the inflamed connective tissue, and thereby facilitating the optimal cleaning of the root surfaces. The original Widman flap starts with 2 releasing incisions and a submarginal incision in the facial and palatal or lingual aspect, so it is a rectangular flap. You can see the 2 releasing incisions in this picture. These incisions were made from the mid-buccal regions in the originally described Widman flap, but today we know that it is better for the releasing incision to start from the line angle of the teeth. A scalloped reverse bevel incision is made in the gingival margin to connect the 2 releasing incisions. After you've made the first incision, a mucoperiosteal flap is elevated to expose at least 2 to 3 mm of the marginal alveolar bone. Then we remove the collar of the inflamed tissue around the neck of the teeth so that we can expose the root surfaces. Then we carefully instrument the root surfaces. After that, a bone recontouring must be initiated to establish a physiologic, ideal, positive architecture of the alveolar bone. The negative architecture means that the interdental bone is more apically placed, which usually happens in periodontitis because the deposits are mainly in the interdental area. But we want to make the physiologic positive architecture, which means that the interdental area needs to be more coronal relative to the radicular surfaces. Widman pointed out the importance of placing the soft tissue margin at the level of the alveolar bone crest at the end of the surgery so that no pocket would remain. Then buccal and lingual flaps are laid back over the alveolar bone and secured in this position with interproximal sutures. So when we want to have no pocket to remain, the interproximal areas are usually going to be exposed. So there's going to be no soft tissue coverage over the interdental crestal bone. This is the main weak point of the original Widman flap. Only a few years later, Dr. Neumann suggested the use of another flap design which differed from the one described by Dr. Vidman in that an intraclavicular incision, so a sulcular incision, is made through the base of the gingival pockets. Following flap elevation, the inside of the flap was curetted to remove the pocket epithelium. Also, the granulation tissue is removed. The root surfaces are carefully debrided, and the irregularities of the alveolar bone crest are corrected as in the original Widman flap. Finally, the flaps are trimmed for an optimal adaptation. So the only difference is that the incision used in Neumann flap is an intraclavicular or a sulcular incision. Another flap that was introduced in 1931 was the Kirkland flap or modified flap operation. Kirkland also uses intraclavicular incisions or sulcular incisions. After that, the buccal and lingual flaps are retracted to permit proper root debridement, but no soft or hard tissues are eliminated in Kirkland flap. Just the pocket epithelium and the granulation tissue is removed from the inner side of the flap. So no bone is removed, and the flaps are replaced in the original position at the end of the surgery. So it's basically just an access flap to allow proper root debridement. It was suggested by Dr. Kirkland for aesthetic reasons, and also he suggested that a sulcular incision has a regenerative advantage. It gives the intrabony defect the chance to regenerate. In the mid-1950s, the focus of periodontal surgery shifted towards the aim of preserving an adequate zone of attached gingiva after surgery once the periodontal pockets had been eliminated. Before that, the only aim was pocket elimination. But after that, it was discovered that attached gingiva is also important, and we don't want to remove the attached gingiva by subgingival incisions. This was introduced by Dr. Neighbors in 1954, Dr. Araju and Tyrell in 1957, and carefully described as Apically Repositioned Flap by Dr. Friedman in 1962. He is also famous for iatrosedation. He has lots of articles about dental phobia and how to make patients overcome dental phobia, which I won't get into. In the apically repositioned flap described by Dr. Friedman, a reverse bevel incision, dependent on the pocket depth as well as the thickness and the width of the gingiva, is used. This beveling incision follows a scalloped outline to ensure maximal interproximal coverage of the alveolar bone. Vertical releasing incisions are also used to make the apical repositioning of the flap possible. If the gingiva is thin or if only a narrow zone of keratinized tissue is present, the incisions have to be closer to the tooth. They are less subgingival. After that, a mucoperiosteal flap is elevated beyond the mucogingival line, and then the tissue collar has to be resected to remove the pocket epithelium and the inflamed connective tissue with a curette. Osseous surgery is performed with the use of a rotating burr to recapture the physiologic contour of the alveolar bone. We also want to establish a positive bony architecture if possible here. Finally, the flaps are repositioned in an apical direction to the level of the recontoured alveolar bone and are retained in this position by sutures. A periodontal dressing has to be placed over the surgical area to ensure that the flaps remain in the correct position during healing. But we know that we cannot just use this kind of apically repositioned flap in the palatal of maxillary teeth because there's no mucogingival junction there. So the palatal flap cannot remove to a more apical area. So we have to use a modification there, which was described by Dr. Friedman as the beveled flap. In the beveled flap, the primary incision is sulcular, it's intraclavicular, and a conventional flap is elevated, scaling, root planing, and osseous recontouring is performed, and at the end of the surgery, the palatal flap is replaced and the secondary scalloped reverse bevel incision is made. So we make the subgingival incision at the end of the surgery after we've established where the remaining alveolar bone height is placed. It's why it's called the secondary reverse bevel incision, which is also scalloped so that the interdental bone is not exposed at the end of the surgery. The shortened and thin flap is replaced over the alveolar bone and in close contact with the root surfaces. Another flap was described by Dr. Ranford and Dr. Niesel in 1974 called Modified Widman Flap or Open Flap Curettage. It should be noted, while the original Widman Flap technique included both apical displacement of the flaps and osseous recontouring, which is the elimination of bony defects to obtain proper pocket elimination, the Modified Widman Flap technique is not intended to meet these objectives. The main advantages of Modified Widman Flap, according to the authors, are the following. First, in a Modified Widman Flap, we have the possibility of obtaining a close adaptation of the soft tissues to the root surfaces. The second one is that Modified Widman Flap has only the minimum amount of trauma to the alveolar bone and the soft connective tissue. The third one is that less exposure of the root surfaces occurs, which can be advantageous from an aesthetic point of view for the patient relative to the previous flaps that I've described. But nowadays we have much better flaps to use in the aesthetic zone, such as the Papilla preservation flap. But in that time zone, the Modified Widman Flap was the most aesthetic kind of flap that you could use for periodontal flap surgery. The initial incision is placed 0.5 to 1 millimeter from the gingival margin. It is parallel to the long axis of the teeth. If the pockets on the buccal aspects of the teeth are less than 2 millimeters deep, or if aesthetic considerations are important, an intraclavicular incision is recommended. In the palatal area, you can place the incision more subgingival, 1 to 2 millimeters, because it's not important from an aesthetic point of view, and also you have more keratinized tissue. Vertical releasing incisions are not usually required, but are not also contraindicated. Following careful elevation of the flaps, a second intraclavicular incision is made to the alveolar bone crest to separate the tissue collar from the root surface. And then a third incision is made perpendicular to the root surface, and it has to be as close as possible to the bone crest so that you can separate the tissue collar from the alveolar bone. We only expose 2 to 3 millimeters of the alveolar bone crest in the Modified Widman Flap. If you expose more of the bone, this flap loses all its advantages. And you also have to be careful that residual periodontal fibers attached to the tooth surface should not be disturbed in this kind of flap. Following proper debridement and curettage of angular bone defects, the flaps are carefully adjusted to cover the alveolar bone and sutured. Complete coverage of the interdental bone as well as close adaptation of the flaps to the tooth surfaces should be accomplished. The flaps are then trimmed and adjusted to the alveolar bone to obtain complete coverage of the interproximal bone, which is very important. If this adaptation cannot be achieved by soft tissue recontouring, some bone could be removed from the outer aspects of the alveolar process in order to facilitate proper flap adaptation. But generally, we do not remove any bone in Modified Widman Flap. We only remove a little bone at the end of the surgery, only if we cannot obtain complete adaptation in the interproximal area. Healing of Modified Widman Flap starts by the organization of a blood clot. It usually takes 2 to 5 weeks, and for a mature long junctional epithelium to occur, it can take several weeks. So it usually is recommended to not probe the area after surgery for 2 to 3 months. And if you have used a regenerative surgery, you should avoid probing or deep scaling for about 1 year. But for resective surgeries, 2 to 3 months is sufficient. The next kind of flap that I want to discuss is the distal wedge procedure, which is also called the distal terminal molar flap or retromolar flap operation. In many cases, the treatment of periodontal pockets on the distal surface of distal molars is complicated by the presence of bulbous tissues over the tuberosity or by a prominent retromolar pad. Some of these osseous lesions may result from incomplete repair, after the extraction of impacted third molars. This area frequently presents limited amounts of keratinized gingiva or the presence of distal, angular, bony defects, which makes the removal of this tissue by gingivectomy contraindicated, because gingivectomy doesn't give us access to the bony defects and also removes the limited amount of keratinized gingiva. Distal wedge procedure was originally described by Dr. Robinson in 1966. The distal wedge procedure in the distal of mandibular molars is usually as described in this picture. Buccal and lingual incisions are made through the retromolar pad to form a triangle in this area, and a triangular shaped wedge of tissue is dissected from the underlying bone and then it is removed. Finally, you have to reduce the thickness of the buccal and lingual flaps. Usually most of the people forget to do this step. If you do not reduce the thickness, then you cannot achieve primary closure in this area, and also you're gonna have the pocket recurrence. In the maxillary molar area, we usually use modified incision techniques to ensure optimal flap adaptation at the forcation site. Look, in the mandibular area, we do not have a forcation at the distal site, right? The forcation only exists at the buccal and lingual. But in the maxillary molar region, the forcation is in the distal. So if I place my incision in the distal exactly at the forcation entrance, this could cause a problem. To ensure the best possible flap adaptation at the distal forcation site, I can place my incision more palatal. The amount of attached keratinized tissue also is important and is considered when placing the incision, so that we do not remove the precious keratinized tissue from the buccal area. The modified distal wedge procedure is usually used at the distal of the maxillary molar with two parallel reverse bevel incisions, one buccal and one palatal, which are connected with a buccolingual incision at the end. To ensure primary closure of the distal flaps, especially in the tuberosity, it is advantageous to use one horizontal incision or two horizontal incisions that are closer together rather than further apart. The buccolingual distance between the buccal and lingual incisions depends on two criteria: the transgingival probing depth in the distal and also the amount of the fibrous tissue involved. Generally, the distance between the two parallel incisions is about 1/2 to 2/3 the distal transgingival probing depth. So if the distal transgingival probing depth is 6 mm, the distance between my buccal and lingual incisions must be 3 to 4 mm, and they should never be further apart than the distance between the buccal and lingual line angles of the tooth. The two parallel distal horizontal incisions in the maxillary tuberosity are advantageous relative to the triangular shaped in allowing the soft tissue along the whole length of the distal flap to be evenly displaced. This results in a wide angle which is easier to clean. But if you use a triangular incision, it's gonna cause an acute angle which is harder to clean, and it's gonna cause plaque retention in the distal area. The mandibular retromolar tissue ascends distally to merge with the ascending ramus, so the anatomy of the retromolar pad is more compatible with the triangular incision. But you also have to be careful about the lingual nerve and also the keratinized tissue, which can make our incision go more buccal or more lingual. The distal wedge excision has a half-moon shaped inverse bevel incision from mid-buccal to mid-palatal aspect. The palatal incision, which is usually 10 mm distal. And finally, if needed, we can use a gingivectomy too to eliminate redundant tissue. It usually happens if There's a lot of tissue at the distal of the last molar. For example, when your last molar is the first molar. The distal wedge procedure is not simply removing a wedge of tissue distal to the terminal molar to reduce or eliminate a pocket. Well-executed distal terminal molar flap surgery requires the flaps to approximate intimately to allow for primary closure and in an apical position to achieve pocket reduction. So we usually use anchor or closed anchor sutures after the distal wedge surgery, which is generally a simple interrupted suture, only it circles around the last molar tooth. The other flap that I want to discuss is the undisplaced flap. Currently, the undisplaced flap technique may be the most frequently performed type of periodontal surgery. So the most common type of flap used is usually the undisplaced flap, unless we have limited keratinized tissue. For the undisplaced flap, the submarginal scalloped internal bevel incision is initiated at a distance from the tooth, roughly 1/2 to 2/3 of the interdental transgingival probing depth. So if my interdental transgingival probing depth is 6 mm, the distance of subgingival incision in the mid-buccal or mid-palatal area is going to be 3 to 4 mm if there is sufficient attached gingiva. By sufficient attached gingiva, we usually mean 3 mm. Therefore, the two anatomic landmarks, the transgingival interdental probing depth and the mucogingival junction, must be considered to evaluate the amount of attached gingiva that will remain after surgery. The internal bevel incision should be scalloped to create surgical papilla, which are essential to covering the interdental bone. If your incision is not scalloped, your interdental bone is gonna get left exposed at the end of the surgery. If the tissue is too thick, the flap margin should be thinned with the initial incision by the angle of the internal bevel incision. So if my incision is very subgingival, I'm going to expose the bone. If my incision is closer to the gingival margin, I'm going to have pocket recurrence. So I'm going to need to place the flap margin at a level that neither of these problems occur. You can see the 3 incisions necessary for flap surgery in this picture. A describes the first or internal bevel incision. The second one is the crevicular or sulcular incision, and the third one is the interdental incision, which is perpendicular to the tooth, close to the crest of the bone. A short mesial vertical incision can be used to allow flap release on the palatal area, or when we want to avoid the extension of the flap to the aesthetic zone. Full thickness flaps are reflected 1 mm beyond the mucogingival junction. The gingival color and the granulation tissue are removed with curettes. Then the root surfaces are completely scaled and root planed. Finally, osseous recontouring is performed to eliminate defects and reestablish positive bony architecture. Apically displaced flap is used when the amount of attached gingiva is minimum. It is less than 3 mm. So the internal bevel incision is made as close to the tooth as possible, usually 0.5 to 1 mm subgingival, or it could also be sulcular as well. No need exists to determine where the bottom of the pocket is in relation to the incision for the apically displaced flap, as one would for the undisplaced flap, because the flap's final position is not determined by the placement of the first incision, and the flap is placed at the tooth-bone junction. With some variants, the apically displaced flap can be used for pocket eradication, widening the zone of attached gingiva, or both. Depending on the purpose and the thickness of gingiva, the apically displaced flap can be a full-thickness flap or a split-thickness flap. Vertical incisions can be used, but are not always necessary for an apically displaced flap. If a full-thickness flap is reflected, an independent sling suture is used, and also a dressing has to be applied. For a partial thickness flap, the same is used, but also periosteal sutures are going to be needed. By a sling suture, I mean the suspensory suture technique. Finally, I want to talk about the Papilla preservation flap, which was described by Takei in 1985. Its main aim was to preserve the interdental soft tissue for maximum soft tissue coverage in the interdental area, which can be used for regenerative therapy or for aesthetic reasons. So the incisions here are intrasulcular without making incisions through the interdental papilla. Then you use a semilunar incision, which is at least 5 mm away from the line angle of the teeth in the palatal area, so that the interdental papilla is elevated with the facial flap. In a modified version, the incision can be placed in the buccal so that the interdental papilla is elevated with the palatal flap. There are many modifications of papilla preservation technique which I don't want to get into in this video, but I've described them in another video. So finally, let's talk about which technique should I use for moderate to severe periodontitis flap surgery in the posterior area. In the posterior area, because the aesthetic is not important, if you just need access or if you want to do a resective surgery, we usually use undisplaced or apically displaced flap depending on the amount of attached gingiva. But for reconstructive surgery, the first choices are papilla preservation flap or modified papilla preservation flap. The second choice is using a sulcular incision, and the third choice is going to be using a modified Widman flap procedure. In the anterior area, because it is important aesthetically, usually the first choice is not using surgery at all and resolving the problem by non-surgical therapy, but sometimes it's not possible and we have to use surgery. In those circumstances, your first choice is going to be the papilla preservation flap or the modified papilla preservation flap. If the interdental space is minimum, we can use papilla split technique or simplified papilla preservation flap. If aesthetic is not important, we're going to use modified Widman flap, which is 1 to 2 mm subgingival without thinning the flaps. So as you can see, modified Widman flap is here recommended when the aesthetic is not important. And finally, when advanced osseous involvement is present, we have to use apically displaced flap with bone contouring. You may ask, why not undisplaced flap? Because if you use undisplaced flap in this circumstance, it means that your submarginal incision has to be very distant from the marginal tissue, because the only time that the advanced osseous lesion has happened is advanced periodontitis. So it's better to place the incision closer to the margin and use apically displaced flap to also increase the attached gingiva. I hope that this video was useful for you, and you can find more videos on my YouTube channel @ Samira_Mirzapour. Thanks for watching. Good luck.